Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Everyone, I am so glad, as per usual, that you've decided to join us for another episode of the Research Works podcast.
Yes, welcome back. We have another great episode lined up for you today. We have actually one of the keynote speakers from the most recent EACD conference in 2023 on the show.
Yep.
His keynote was, by all accounts, extraordinary. He's a great storyteller, a great researcher and clinician. Please welcome Dr. Laurent Servais. Welcome, Laurent.
Welcome.
Thank you very much. Thank you.
I love that I've now got to Ash to say people's names because I did such a terrible job and she gets the accent much better than I do. So I was at EACD and I absolutely loved your keynote. I think I've told you that like a million times now. I saw you wandering the halls of the poster area and I kept seeing you. And I thought, I've just got to go down and find him and get him and just get him booked in. And we literally stood there with phones going, we just got to book this in. So here we are. So, yes, I think this is going to be a great topic to talk about, and we're going to intro all of that in a little bit soon. I would actually say it's probably one of the most exciting areas of medicine, science, advancement, and watching it from the outside and actually seeing the impact it has even on the patients I've been working with has been amazing.
Yeah. And a relatively new topic for the podcast as well, which is also, I'm really excited to get stuck in. And thank you for joining us so early in the morning where you are, Laurent. We really appreciate it. So the article we want to base our conversation on today was recently published in Developmental Medicine and Child Neurology. It's titled Financial Cost and Quality of Life of Patients with Spinal Muscular Atrophy Identified by Symptoms or Newborn Screening. Before we get into all of that though, let's tell our listeners a little bit more about you, Laurent. So Laurent Servais is a professor of paediatric neuromuscular diseases at the MD UK Oxford Neuromuscular Centre and invited professor of child neurology at Liège University. Recently, Professor Laurent served as head of the Institute of Myology's iMotion, which stands for Institute of Muscle-Oriented Translational Innovation, and the head of Neuromuscular Centre in Liège, Belgium. Professor Laurent has been involved in some of the world-leading clinical trials, testing treatments for Duchenne muscular dystrophy and spinal muscular atrophy. He's a leader of the newborn screening program for SMA in southern Belgium. It's a pretty incredible body of work.
Amazing. It is pretty amazing indeed.
Yeah. And thank you, Dana, for all those tricky words in the intro.
Sorry, but you do it better than I do. You're definitely better at it.
Laurent can give me feedback on my accent later on.
I do know it's Liège, though. It's Liège, isn't it?
Yeah, Liège is good. I mean, you do it well. Yeah, you've got a good Liège.
Liège, or see, this is where I can show off just a little bit. Or Luc. Luc, is that how I say it? That's like the Flemish version. How do you say it?
Yeah, the Flemish version is Luik, and the German version is Luti, because Liège is close to three borders, the borders of the between Belgium and Holland, and on the east side between Belgium and Germany. Wow. So we have three names for the same city.
You have to cover all your bases.
You do indeed.
Exactly.
You do.
Exactly.
Yep. I only know that because we're trying to catch a train out one day. We flew in to Brussels, but it was a no car day, so we couldn't get a car out. So our family said, catch the train to Liège. We're like, okay, we get onto the train. And there's no sign of Liège anywhere, but there's a place called Luc. I can't say it properly. And we're like, I think we're going to head to the wrong place. But it's because there's three different names in the city. And that's why I got so lost. That's the only reason why I know about Liège.
There you go.
There you go.
So, Laurent, we like to start with a little icebreaker. I feel like we had a little Belgium icebreaker just there, but we will ask you an additional icebreaker. You can't, unfortunately, get out of that one.
It's very popular topic.
It is. Our icebreaker question today is, what do you admire most in a work colleague? So we can give you a little bit of time to think
general,
Oh, he's got it. He's got it.
You know, it's, okay. I still have a little bit of time to think. That's fine.
I let him off the hook.
Okay, no, that's fine. So what I admire most is certainly the colleagues who are able to bring gene therapy or innovative therapy to a child as academic, because we all know, the difficulties of bringing a new drug from mice to humans. And when you have no pharma companies behind you and not all the system to do it, and you have to do it by yourself, I think it's incredibly brave.
Wow.
Most of the time people have no idea of what it means, but being able to do that and being able to work both sides on the bench and the bed is becoming incredibly rare. I have a deep admiration for colleagues who are able to do that.
Gosh, that is amazing.
Yeah.
Yeah.
I agree with that.
They're they're very distinct skills, and it takes a lot of bravery, absolutely, to step out and translate that. You're so right. But the difference it's made is significant.
Yeah.
So significant.
Yeah. What about you, Dana?
That's a hard one to follow.
It is.
Maybe it goes in the same vein as that, is that what probably drives those people to do that and be brave is passion. I feel like, a leader is someone who's really passionate. Hopefully it's not a misguided passion, but it's, it's passionate about an area. You're willing to step out and do more because you believe in the cause. And when you see people who are passionate about something, you can't help but to get behind it. And you can definitely wield it for good.
Yeah.
So I think you can bring people with you.
Yeah.
So
I love that.
yeah, I love that part of it.
Yeah.
Just passion. Yeah.
Yeah.
What about you?
I admire all of those things that you've both covered. And I think if someone can do all of those things and maintain a really good sense of humour,
I like that.
I think I admire that because, a lot of the work we do is quite challenging and, involves a lot of long hours and, lots of deadlines and all those things. And if you can, you're prepared to work hard, but you can do that while you maintain a sense of humour and curiosity about the world, then I really admire that.
It's a good skill to have, actually. It's true. You need someone like that in the team.
Yeah.
And those late nights.
Definitely.
Good question. One that got us thinking with this one. I like it. All right. Well, let me give you a bit of a rundown about what we'll be talking about today. And we can't wait to ask lots and lots of questions. There's some big words coming up too. And I'm pretty sure I put them in your column again.
Yeah. Thank you for that.
You're welcome. You're welcome. So spinal muscular atrophy is the most common genetic cause of infant mortality, with an incidence of approximately 1 in 10,000 live births. With the introduction of 3 drugs approved for use in SMA, we have started to observe improvements in functional capacity and quality of life. However, these drugs are very expensive. This study analysed disease-related costs and health-related quality of life in 3 broad categories of patients with spinal muscular atrophy. So untreated symptomatic patients, treated symptomatic patients who were diagnosed because of the onset of symptoms, and then treated and patients not identified by symptoms who were identified from early testing. So the study found that patients not identified by symptoms had better motor development, better quality of life, and much lower disease costs than treated symptomatic patients.
So interesting.
Very interesting.
Okay, before we get into, I suppose, the really kind of key messages in that paper, Laurent, this is the first episode we've had so far on the podcast about spinal muscular atrophy, or SMA, and it's an area that you're a world leader in, so we're very fortunate to have you to guide us through this today. Before we get into the article itself, I thought it would be great if we could take a bit of a step back and talk with our listeners about what SMA is and what the current treatments for SMA are. So could you start with a broad overview of what SMA is?
Well, yes, for sure. And we could start with a patient, right?
Yeah.
With the story of a patient. You have a baby. This baby is, of course, the most beautiful of the world. He or she is smiling and is entirely normal at birth. And then during the first months of life, this baby starts being a little bit floppy, and then you go to your pediatrician, and the pediatrician says, well, maybe he's a little bit, tired or lazy or whatsoever. But then it ends up that your baby starts losing some head support and not being able to progress from a motor perspective and start having difficulties in breathing. And unfortunately, the diagnostic of spinal muscular atrophy could eventually come. So when this diagnostic comes before the onset of treatment, it's a death sentence. A death sentence that is for in median time about 5 months. Wow. So it's a terrible condition.
Yeah.
So spinal muscular atrophy is related to the absence of a protein that is called SMN, spinal motor neuron protein, spinal motor neuron survival protein, and this protein actually is coded by a gene that is called SMN1, and this protein is very important for several cellular processes, including splicing, but also axonal generation. And what happens is that if you miss it, the motor neurons are especially sensitive to the absence of this protein, and the motor neurons, which are these cells that give the order to muscle cell, will eventually die.
Okay.
If they die, the muscle cell, they don't know what to do, and they get atrophy, and then the child will develop proximal hypotonia and weakness, and then difficulties in breathing, and eventually will have difficulties in swallowing and die. This isn't the most severe and most common form, which we call SMA type 1. And then there is another form that is called SMA type 2 and type 3, in which that will start later, and kids will be able to sit in SMA type 2 and to walk in SMA type 3. But in all cases, it's going to be a neurodegenerative condition, and the children will lose the ability that they have acquired.
Wow. Okay.
And so when someone says, well, SMA type 3 is a less severe condition, well, yes, it's a less severe if you compare with SMA type 1 that kills the baby in 5 months. But I don't call a mild condition a condition that leads you to lose ambulation when you are 12 years old, right? This is never a mild condition.
No.
And the interesting point is that actually, whatever, if we talk about SMA type 1, type 2, type 3, this is related to the same mutation in the same gene, which is a deletion of exon 7 of SMN1. 96% of cases, 96%. In 4%, it can be a point mutation in the other allele. But in 96% of cases, it's a deletion of homozygous deletion of exon 7.
Right.
So which makes it a perfect candidate for newborn screening.
Yeah.
And so you could say, okay, that's fine, but how is it possible that the patient may have such a severe form or a milder form with the same mutation? It's because we have another gene that is called SMN2, which is nearly similar to SMN1, but produces only a little bit of protein, because the exon 7 is nearly systematically spliced during the splicing process of SMN2. Which opens, of course, a way for potential treatment by modifying the splicing of SMN2 and to allow a better production of SMN protein from SMN2. So, which is interesting is that we have now 3 treatments that are approved by FDA, EMA, and that are also available in Australia, as long as I know.
Yep.
Yeah.
And you can either work on SMN2 and produce more protein from SMN2 by interacting with the splicing of the RNA of SMN2. But you could also bring a new gene of SMN by gene therapy. So we have now 3 therapies that are available for spinal muscular atrophy, which is quite amazing for such a rare condition.
Yeah. And you say it's a rare condition. So what kind of incidence are we talking about for SMA?
Well, actually, I used to say it's rare, but not that rare, because it's about 1 out of 10,000. What does it mean? How many newborns do you have per year in Australia?
Ooh,
Do you have any idea?
You're testing me here.
Yeah.
No, I don't
Actually,
I
no,
can check it.
you
I can check it.
Google it now.
Yeah.
Shall I do that?
A live Google? Why not?
Yeah.
Okay.
Newborn per year. So let's imagine that, well, you have actually 309,000 newborn per year in Australia in 2021, right? Which means 30 or 31 new cases of SMA in Australia per year.
Wow.
So it means about nearly 3 kids per month, 1 kid every 10 days in Australia. Let's say 1 kid every 11 days.
Yeah.
So every 11 days, there is a child born in Australia with spinal muscular atrophy.
That doesn't feel very rare, does it, sometimes?
No.
Yeah.
No.
Given what kind of condition that it is. I was really interested when you said then about, even if a child has type 3 and they can walk, they're not going to be able to maintain that for life. It is a neurodegenerative condition. Is it, you mentioned 12 years of age there. Is that a common age where walking tends to sort of drop off, or is it quite variable in terms of skill attainment and retainment, I guess?
It is variable. It depends when the child will start the symptoms, and as usual, the earlier the child starts the symptoms, the more severe will be the condition.
Yeah, okay.
But the most frequent is that these kids lose ambulation during puberty, because during puberty they start growing, and growth is always the enemy of patients with neuromuscular disorders.
Yeah.
So we have, unfortunately, as child neurologists, many patients will get much worse during the puberty. So not all patients will lose ambulation around the age of 12, but all of them will start the symptoms before the age of 4 will.
Yeah, okay.
And some patients could maintain ambulation, but which is important to understand, because it will have deep implication for the discussion about treatments, is that there is no mild spinal muscular atrophy. If you tell a 6-year-old, well, you're going to have more and more difficulties in walking, running, climbing stairs, and eventually you will lose ambulation.
Yeah.
This is terrible.
Yeah.
I mean, it's just because we used to benchmark with a disease that kills the baby in 5 months that we say that it's milder.
Yeah.
But I don't call it a mild disease.
Yeah.
No, the impact certainly isn't. And we talked a little bit about current treatments, and I'm really interested to hear more about the treatments that are available. But I suppose the step before that, how do we diagnose SMA at the moment?
Well, there are different ways of diagnosing SMA. The classical way is to wait that the patients have symptoms. And then, as I explained you with the story of my baby with SMA type 1, it can take a little bit of time because it's quite a rare condition, right? So most of first-line healthcare practitioners have never seen a SMA patient, right? So they will probably not think about it immediately. So there is what we call a diagnostic odyssey, right? And when it comes to a more chronic form that starts even more slowly, and that can be, that can mimic other conditions that are more common, like orthopedic conditions, or sometimes the child is sometimes people even believe in a psychiatric condition. So it can take years sometimes for SMA type 3, for instance.
Wow.
So the median diagnostic time is about 3 months when it comes to SMA type 1, but 3 months between the moment when mom says there is something going wrong here and the final diagnosis. So you can imagine what means 3 months when your baby is worse and worse by day. And in SMA type 3, we're talking about several years. So it's several years of investigation, of back and forth in the hospital. And you can imagine the anxiety and difficulties for families that are waiting a diagnostic for several years. So that's let's say the classical form. And then for the last 5 years, there is a new way of doing, which is newborn screening, which means that all newborns have a test for the last 50 years to screen for metabolic disorders like phenylketonuria, and this is true in nearly every country of the world. But on top of the classical diseases that we are trying to identify with newborn screening, we can add quite easily spinal muscular atrophy, because it's all patients have the same mutations, right? Yeah. They all have the same deletion in exon 7, and we could potentially, and we do it now, identify it by a simple PCR.
Wow.
Unfortunately, we're still missing the patient with a point mutation. So this 4% of patients, we're still missing them. So today we still identify these patients when they start having symptoms, and it's even more difficult because, as you might imagine, we are less and less used now to recognize this disease when it happens, because there are less and less cases that are identified per symptoms. So it is more and more challenging to recognize these cases. I can
understand that, because if you are doing screening early on and starting treatments, you're now not seeing the progression, and so you're not, won't be looking out for it necessarily, which is really interesting. With the screening, can I just ask which countries or who's doing the newborn screening at the moment?
So it's not all countries. Actually, in the United States, nearly 100% of patients are screened nowadays. In Europe, it's about 50%. And there are still large countries in Europe in which you don't have national screening. Best example being, of course, the UK, but also France. You don't have a national newborn screening. But very interestingly, the most recent country in Europe that initiated newborn screening, do you know which country is it?
No. What would that be? Feels like it's a trick question.
Icebreaking question. But it's the last country in Europe that started newborn screening for SMA. It's Ukraine. So Ukrainian wanted to start before the war the newborn screening for SMA because they had identified as a perfect target. They could not because of the war, obviously, but as long as they could kick out the Russians of the Kiev regions, back in, I think, July 2021, they could start newborn screening in two regions, Kiev and Lviv, at the west side. And they've identified so far 11 patients. So that's a very beautiful story of resilience. And the ladies in charge have been trained in my team, so we were incredibly lucky to meet them. I've never seen such brave persons with so a dedication for the patients in such a difficult period of time. Yeah. So yes, Ukraine is one of the very last countries to have started newborn screening, and in Australia there is a newborn screening that is currently ongoing, but not in all regions, I think. Okay. You need to check. Okay. And the difficulties in Australia is that some patients cannot be treated according to the number of copies, and I was discussing with an Australian colleague, I don't remember where she's based, but she told me that in her region, kids with 3 copies of SMN2 currently do not have the reimbursement of therapies when they are identified at birth, which is a little bit weird, and this is what we could discuss about the paper that you have selected, is that actually they are probably the best candidate to be treated. And if you think purely from a utilitarian perspective and how to get the best efficacy of a drug and the best value for money, because these treatments cost a lot of money, probably patients identified at birth with 3 copies of SMN2 could be the best candidate to be treated. So yes, it's still heterogeneous, but it's increasing by weeks, the number of countries. Great. And we have projected that in 5 years, probably more than 50% of kids around the world where the treatments are available could be screened for spinal muscular atrophy.
That's amazing.
Yeah, such an opportunity,
Gosh,
isn't it?
yeah.
So, Laurent, let's talk about what those treatments are. So there's since 2017, there's 3 drugs that have been approved for use to treat SMA. Can you talk to us about what they are and what they do?
For sure. So the first drug that was approved is an oligoantisense nucleotide. It's like RNA, but it's much more robust than RNA. Okay. It's not immediately destroyed by the RNAs. And so it can interfere with the splicing of SMN2. Wow. But you have to inject it intrathecally. So it's like, during a peridural anesthesia, and you have to make 4 doses at day 1, day 15, day 30, day 60, and then every 4 months for the rest of your life.
Yeah.
It has been demonstrated to be extremely safe. It's a very safe drug. And there are 2 pivotal trials that have shown the efficacy. The second drug is an oral medication. It's you can take it orally every day. Okay. It also interacts with the splicing of SMN2. It's a small molecule. And it has also been demonstrated to be very efficient in all types of SMA, and it's also very, very safe. Okay. And the third drug is gene therapy. So gene therapy is actually a vector, like a virus, a capsid, from which you remove the DNA of the virus, and you place a promoter, which is motor neuron specific, and the gene that is missing. And so this is infused like a one-shot therapy, because after this infusion you will get antibodies against the virus. Right. Of course, your body is not super happy to see this amount of virus coming all of a sudden, so you need to temper the immune reaction using steroids. And it has been also demonstrated to be very efficient. We now use this type of therapy in kids who are younger than 2 years old, and with a weight that is below 23 kilos. But they are, more and more experienced to try to, go in a broader population using, for instance, intrathecal injection of this therapy. The gene therapy is also quite safe, but we can have some serious adverse reaction, including liver toxicity or severe immune reaction. So it is certainly a drug for which we need to think carefully about the benefit and the risk, then with a little bit more risk than with the 2 other ones. All these drugs have common points. Let's say at least 3. One, the effect is impressive. There is no doubt about the effect, but especially when it's given early. And all trials and all studies have demonstrated that the earlier you give the drugs, the better it is. Right. It's quite easy to understand. The disease is related to the death of motor neurons. Motor neurons is a cell that will not replicate. When a motor neuron is dead, it's forever. So you have no drugs that will make new motor neurons appear. Right. It means that if we want to keep a maximum number of motor neurons in these kids, we have to treat as soon as possible, because, again, when it's too late, when the motor neurons are dead, you will not make new motor neurons appear. So a third common point between these drugs is obviously the cost, which is huge. And I don't know the cost in Australia, but the cost we're talking about in the US, for instance, is one shot of nusinersen, so this drug that you inject intrathecally, is about $100,000. Right? Wow. And you have to give it every 4 months. Let alone, of course, the cost of the hospitalization, because you have to bring these kids in the hospital. And the gene therapy, we talk about $2 million, right? Wow. So the the cost of these drugs is enormous. We need to appreciate and to understand again that this is a rare condition. So the cost of the drug can be huge, but the impact on the budget is low. Because if you consider, for instance, a much more common condition, I don't know, like diabetes mellitus or high blood pressure, and you increase the cost of the drugs, the impact on the budget will be much more important than when it comes to a very severe but rare condition.
That's a really good point. And what about the oral medication, just out of interest? Like, is there a discrepancy between how much that is relative to the ones that are administered intrathecally?
You mean in terms of cost?
Yeah.
Well, in terms of cost, it doesn't change anything. It's 1 year of treatment is about $300,000 in the US. But we need to appreciate that the cost of medication is not related to the cost of the production or the cost of the development. The cost of the drugs is mostly a negotiation between the pharma companies and the state or the payers, and it's based on the benefit of the drug. And there are other mechanisms and other things to consider, like for instance the budget impact. But how we decide how the price of a drug is decided is a complex story, which is different from one to another country, by the way. So no, the cost is not different. So treating a patient with SMA with these new drugs costs a lot of money. But there is something else to consider here, is that even if you don't treat these patients with these innovative therapies, SMA itself costs a lot of money. Because let's imagine a patient with SMA type 2 who is a patient who is going to sit but will never walk and will be wheelchair bound for his entire life. Every 4 years or 5 years you will have to change the wheelchair.
That's right.
Many of these patients have a non-invasive ventilation, they have physiotherapy several times per week. So the cost of the disease itself is huge. And even if you forget about expensive medication, a patient with type 2 will cost about $5 to $7 million of dollars during his lifetime. So the cost of the drug is certainly important, but the cost of the disease is even more.
It's very complex in terms of how it's managed.
It's very complex, and the patient, the less expensive patient, if I might say, are patients with type 1, because in the absence of treatment, unfortunately, they will die. So it means that the cost will be huge during 1 year, but then it's over. So it's a very complex system when you try to figure out what is the impact of these drugs on the cost for the system, because on one hand, you can avoid all the costs that are related to disability, to wheelchair use, to ventilation, but on the other hand, you keep alive kids who will remain with very high costs during their entire life, rather than being concentrated during one year. So it's a difficult equation.
Definitely. And I feel that leads us quite nicely into the aims of the paper that we are covering today. So, Laurent, in a nutshell, could you tell us what the aim of this paper was?
Well, the aim of this paper is to estimate how much does it cost to treat a patient with spinal muscular atrophy and how much money we can save in 3 scenarios. Scenario number 1, when we have no treatments available. Scenario number 2, when we wait for the patients to present the symptoms, we identify these patients and then we treat them. And scenario number 3, in which we have a newborn screening. So we have identified the different costs, but also the benefit. What do we gain in terms of years of life and quality of life? So we have investigated the benefit and the cost of these 3 scenarios.
Gosh, it's very complex. And as I was reading through it in terms of how you did the calculations, it It was wonderful because when you talked about the cost of illness, you sort of went through it in brief there as well. It's not just the cost of the drug, like you said, it is time off work. It's the ability for parents to continue to work. And then you put alongside that going to appointments, home care versus their quality of life. And I like how in the paper you really just, by presenting all those different options, it makes everyone think really deeply about what we need to consider because yes, the cost, like you said, of those drugs is very high, but when you consider all of these other factors about quality of life and all the other aspects, the benefits, it was a very compelling question to be able to ask. I do have a quick question on that one in terms of who you included for this, because to do this kind of study, you would have had to include quite a few patients on databases, I suppose. Is that how it was done?
Yes, so you have two types of approach in such study. The first one is to have a very broad approach and to go, for instance, in the US on insurance claim for several codes. The way we did in Belgium, which is a very, very small countries with only 60,000 newborns per year. When it comes to southern Belgium, where the diagnostic, where the newborn screening was in place, was to try to have a very precise evaluation of the cost, even if the number of patients was limited. So we considered all the patients that we personally knew, and the beauty is that our center is the only one for the regions, what we call Wallonia, in southern Belgium. So we have quite a good vision about these patients, and we started to count the costs that are, as you very nicely explained, the costs that are related to the drugs and to the doctors and to the physiotherapists, but also the costs that are what we call indirect costs. So, for instance, if you have a patient, a child in a wheelchair, you have to change your house or you have to move house because you cannot bring this patient in the stairs. So it means that you need either to have a lift, either to make a room on the ground floor, and the same applies for the bathroom, and the same applies for the loo, and then the same will apply for the car. You cannot go with the car you want. So this comes with a cost, and then, as you might imagine, if you work full time, if your partner also works full time, and you have a kid in the wheelchair with a lot of medical appointment and with ventilation at night, it's just impossible both of you to work both times. So which means that from a societal perspective, you are losing a man or woman, most of the time woman power, and it means that it translates, it comes with a cost for the society. So it's important for everything, and this is impossible to find in databases, right? Because in databases, nobody will write down, okay, mom had to stop working full time and now works like 1 day per week. So it's not in insurance databases. So the weak point of this study is that it's not very large numbers. But the good point is that it's very detailed and definitely adapted to count every single cent for this patient.
You can see that. Yeah, it's very rich data that certainly comes across. So let's talk about some of the key findings from the study then, Laurent. What did you find? What were your key kind of take-home messages?
Well, the key home messages is that, yes, these drugs are very expensive, but the screening doesn't cost so much. The screening cost, so in southern Belgium, we pay €5 per baby, right? Now it's €5 per baby. So it means that for Australia, it would cost something like €1,500,000. I don't know. I'll let you translate into Australian dollars.
We'll have to check the exchange rate.
The exchange rate. So that's the cost of the screening.
Yeah, okay.
But the money that you save with screening is huge, because if you wait these patients to be sick and then to identify them, you will have to pay twice. You will have to pay actually much more than twice.
Yeah.
You will have to pay for the treatment, but you will have to pay for the wheelchair. You will have to pay for the non-invasive ventilation.
Right.
You will have to pay for the house. You will have to pay for the car. You will have to pay for mom who cannot work full time. And I'm not even speaking about quality of life.
Yeah.
But if you screen, the beauty is that you will have to pay once for the treatment, and that's it. And the costs that are on top of that for the patients who are identified by newborn screening are very low. So when you put together the cost of the screening and the additional cost of these patients, and on the other part of the balance, all the additional cost in patients identified after symptoms, you understand very quickly that there is a massive saving for the society to screen.
Yeah.
And so the PhD student who did a PhD about in this research, Tamara, at the end of her talk, she used to say, okay, that's the difference between a patient identified per symptoms, and a patient identified by newborn screening, and she shows videos, and on one side you see a patient running, cycling, and on the other one you see a child in the wheelchair. This is the difference.
Yeah.
But newborn screening, if you don't do it for children, if you don't care of having children running and cycling rather than being in the wheelchair, at least do it for money. Because
that's not compelling enough.
If you don't care of children, please do it at least for money, because it's the best investment that you can do. So let's be clear, these drugs are expensive, but if you are super expensive, but the worst way to use it is to pay twice for the disease and for the drug.
Right. Yeah.
If you really want to get the best use of these drugs, you have to give it at the best window of opportunity. So before these patients become sick, so using newborn screening.
Can I ask on that then? What I'm very curious about is now with these drugs that are here, so we're talking about the fact that these children can move, they are, the trajectory is different. What does that mean? What does that mean for what we see now then? So the children who have had the screening, now they've had the drugs, what could we expect to see? And what sort of, for physiotherapists like me who now see them in clinic, are there any restrictions on what we can do? Do we just go forth and try to get them to move as much as they can, or are there precautions around that?
Great question.
Yeah. So I think things are always a little bit more complex. So we have the patients with 4 copies, and these patients are entirely normal. So I used to tell the parents, okay, let's just look at your child as a normal child, do whatever you want, and let's just have an appointment twice per year to check that we are on the right track. And at the other end of the spectrum, some of these patients, when we identify them by newborn screening, they are already symptomatic. They already present symptoms. So we call them, we meet them immediately. But when we meet them, they have already symptoms. These patients will, for sure, nevertheless need some care and some physiotherapy that we have, of course, considered in our cost analysis.
Yes.
But yes, these patients will need. And then, if you ask me what's going to happen in 20 years, and I answer your question, I'm a liar, right? Because nobody knows. We are learning. We are learning every day by looking at our patients, talking with our patients. We're learning every day about how these patients are doing and what they're becoming with years.
Yeah.
That's a really good point.
And are there things that we need to consider, like in our treatments, considering that obviously, with muscle, we don't want it to be overly fatigued, or, can we be guided by their heart rate? Are there any limitations on what we can do to increase their fitness and endurance, those sort of things?
Well, maybe I'm going to give you a disappointing answer from a physiotherapy perspective. But,
oh no. That's why I asked the question.
Let her down gently.
Yeah.
So I used to tell my families, well, if we have the choice between going to the physiotherapist or going to the swimming pool, go to the swimming pool. If you have the choice between going to the occupational therapist or to go cycling, go cycling. So the reason is that going to swimming pool is an activity that every child can do. So if you, as a child with SMA or identified by newborn screening, you go to the swimming pool, you can go with your friends, you can socialize, you identify yourself as a normal child going to a normal activity. If you go to, if you spend the time and the energy to go to the physiotherapist, you will get the benefit from the physiotherapist. But this is not a place where you will socialize with other kids. And I think that we need to put both aspects in the balance. If you go to the swimming pool, you'll go with mom or dad, you will have the opportunity to bind as a family, and sometimes it's also good for mom or dad to go to swimming pool.
Definitely.
And the type of movements that we recommend are movements that are isotonic and not isometric. What does it mean? If I swim, I move, right? And if I cycle, I move. If I practice judo, I will keep my muscle very hard, but it's not going to be. There is going to be less movement than if I swim, right? So we advise this type of movement for our patients, and indeed it works on endurance. So I used to propose them to have a normal activities, let's say, and activities that develop isotonic movement, regular. And I much prefer. I prefer if they have activities every day rather than to have a lot of activities during 2 hours every week. So regular and isotonic.
No, you haven't let me down at all. No. I feel like that was it's the way we would think.
Very consistent.
You know, it is very consistent. And I think that, you know, there's been such a move away from the traditional way of thinking of kind of going, all right, well, you know, to help with this, we're going to try to fix this and we're going to go to therapy to do this. But, you know, the whole perspective now is participation, and our role can be to advise that and support that and find the sports that are great, be with friends and family, you know, having fun, going to school. And I think those are important. But I love your advice about, you know, the isometric movements and us, you know, encouraging movement across the 24 hours rather than just, you know, one burst of exercise. I think that's really good advice. So, and I'm still feeling hopeful. It's good.
And I was going to say, you know, if a family come to a physiotherapist or occupational therapist because they feel like they need that extra bit of support around them, then they can feel comfortable to take an approach that, you know, leads them down the path of participation.
That's right. Lifestyle. I like that.
Coming together as a family.
Yeah, no, I loved it. That was good. That was good.
So, Laurent, where to from here? What, you know, this is really incredible and exciting work. And I think, you know, a lot of people will read this paper and have lots of questions for you about what the next steps are. So what are the next steps for you and all this work?
Well, the next step is to do 126 times better. So what we've learned from SMA is that to treat these terrible conditions, we have a window of opportunity. And we may have the most efficient drug in the world. If we don't give it the right time and the right patient, it's just a waste of time, waste of energy, waste of hope, and waste of money. So we were very lucky for SMA to have siblings because the efficacy of pre-symptomatic treatment could be demonstrated first in siblings. But in many diseases for which we have now very exciting research, like Angelman, Rett, we have no siblings. So not only we will not be able to conduct pre-symptomatic trials and to accelerate the clinical development. But we will not identify patients before symptoms. So the next step is to change our mind about newborn screening and to have a much more flexible approach of newborn screening. And when I was saying 124 times better, is that what we did in southern Belgium was to browse all diseases in pediatrics, all fields of pediatrics, so not only neuromuscular or neurological conditions, but also ophthalmo, liver, kidney, and to spot all diseases that are severe, that start early, and that are treatable. So severe, start early and being treatable. And do you know how many conditions we found? Well, we found 124 conditions related to 359 genes.
Wow.
So we kick off a pilot to screen at birth every newborns of my hometown in Liège, using genomic sequencing for all these conditions that are severe, that are early onset, and that are treatable, for which we have a treatment. So it's doing quite well. It's moving the right direction. We have already screened about 2,000 newborns.
Wow.
We're very excited, and from a community perspective, we have 91% of approvals, so 91% of parents are happy to sign in for such program. I think that's definitely the next step is to be able to transition much earlier on to pre-symptomatic condition, to kids who can get the maximal benefit of drug, and to be able to accelerate clinical development by getting access to a pre-symptomatic population when we have something that works. That's the next step.
Wow, that's pretty powerful, impactful work, I think.
It really is, isn't it? When you consider, there's a future parent out there that won't know that they might stumble across this as part of their life, and to hopefully be in a country that has newborn screening that would just literally change their life, and change the course of their life. It's significant. So that was very inspiring. Thank you so much. I told you all you would love this talk. It was amazing, right? Next time you see Laurent doing any more presentations, make sure you go and watch as well. He's got some great videos. Obviously, this is a podcast.
Yes.
He can't show videos on the podcast, but, it's really worth looking at because we need to keep an eye out on this work. So Thank you so much for your time today. It was brilliant. Thank you.
Thank you, Laurent. Yeah, we appreciate you getting up early, sharing, the wealth of knowledge you have on this topic and guiding us through it. Yeah, really thoroughly enjoyed it.
Yeah.
It was a pleasure.
Oh, thank you. Thank you. Well, to all of our listeners, we hope you enjoyed that as much as we did. Remember, you can head to our website, researchworks.net. We'll have links to the paper and, of course, to Laurent as well if you want to look at other pieces of work that he has done. And there's a CPD form there that you can fill out as well if you want to keep this as part of a record of your PD requirements. Yeah. But for now, that's it.
Until next time.
Thank you very much. And thanks for listening. We'll talk to you all again soon. Bye.
Bye-bye.